Today presentation is what I want to discuss is when you find a membranoproliferative glomerulonephritis like pattern. So now we know it is just a pattern, it is not a disease. MPGN, which was once labeled as a disease category in which we used to label them as MPGN 1, 2, and 3, and that was mostly applicable to native kidney biopsies. But now, if you talk about transplant biopsies, in transplant biopsies also you see MPGN, and MPGN is now considered more as a pattern rather than a disease entity. And as we know, MPGN can be seen in n number of pathologies. Like for example, the commonest lesion which can have an MPGN pattern is IgA nephropathy. IgA nephropathy can show mesangial hypercellularity. It can show sometimes if there are subendothelial deposits, there could be non-uniform thickening of the glomerular capillary wall. And there could be endocapillary proliferation. So even IgA nephropathy or advanced membranous can show duplication. That can also have an MPGN pattern. Then you have primarily immune complex mediated MPGNs, which can show a MPGN pattern. Even diabetic nephropathy can show MPGN pattern. So I will show few of the disease pathologies, and this is related only to the transplant setting. Okay. So in the transplant setting, the MPGN pattern, I will show you what is a common disease entities which you will consider whenever you find a MPGN pattern. So it will be a case-based kind of presentation. So 52-year female, uh, the basic disease was diabetes and hypertension. And this patient, this is the old biopsy. So a transplant was done in 2019. And this patient had uncontrolled diabetes, progressively rising serum creatinine and proteinuria since the last 5 to 6 months. So presently the serum creatinine is 2.6 milligram. And so this patient has rising serum creatinine as well as proteinuria. Now, if you look at this biopsy, you can see these glomuli which are there. Okay, you can appreciate these glomuli. You can find some blue-looking stuff here. So presence of blue-looking area suggests that there is some amount of interstitial infiltrate which is there. Okay, and you can see these glomuli also. So I'll go to slightly. I'll show other images also, other areas. So you can see this glomulus here. You can see some inflammatory cells, blue-looking cells in the interstitium. That means there is some amount of interstitial infiltrate. In addition to that, you can see these tubules. Just compare these tubules with these small tubules. So these small tubules with a thick kind of tubular basement membrane and reduced lumen, these are atrophic tubules, and there is compensatory dilatation of the adjoining tubules, which is a slightly higher magnification. We can see that Dr. Sagar, I'm in a meeting. I'll call you. बताता हूँ उसका. ATN, 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 ATN. हाँ, बाकी बताता हूँ. Sorry. So if you look at this glomerulus here, so first, if I can ask you, what stain do you think this is? Is this a HND stain, hematoxylin and eosin stain? Is it PAS stain, or is it Mason's trichrome stain? Can you tell me? Anyone? So what stain is there? So even in the chat box you can write. Okay. So the thing is, yes, this is a hematoxin eosin stain, what I'm showing you. So hematoxin eosin stain is a very good stain to highlight that if what kind of infiltrate is there in the interstitium, whether there are lymphocytes, whether there are plasma cells. Now, if you wish to have a look at the glomerular morphology, PAS stain and silver stains, they are the best stains. Now, if you look at this glomerulus, you can see that this is a glomerulus which is there. This space between the Bowman's capsule and the capillary loop, this is called as a urinary space. What you can appreciate is this glomerulus, there is this tuft which is there, then there is a space which is there. Then again, there is a tuft which is there. This tuft like this is there. This is a tuft like this. There is a space again. Then again, a tuft like this. There is a space again. then again a tuft like this. So whenever you find this kind of a spacing between the glomerular tuft, that is called as lobulation. Similarly, just see here that there is a space between this area and this area of the glomerular tuft. Okay, so even this tuft appears separated. So whenever you find lobular, this is called as lobulation. So whenever there is a lobular pattern or lobular accentuation of a glomulus, that is classically seen in a MPGN pattern. It is also labeled as lobular accentuation or a MPGN pattern or a mesangocapillary pattern. Okay. Similarly, look at this glomulus. You can see this is a globally sclerosed glomulus. This is a glomulus which is showing the segmental sclerosis in this area. And these glomuli, they are showing lobular accentuation. You can see a tuft like this, a tuft like this, a separate tuft like this, and then these tufts. So all this suggests that there is a lobular accentuation. So in a transplant setting, whenever you find lobular accentuation, and this is a PS chain. So PS chain highlights that there is a segmental sclerosis which is there. I'll show the high magnification, and you can see that there is a tuft which is like from here to here. Then there is a separation. This is a separation. Then there is a tuft which is like from this area to this area. Then there is a tuft like this, and then there is a tuft like this. Okay, so this is called as lobular accentuation. And lobular accentuation in a transplant setting commonly is seen in chronic antibody mediated process. So based on MPGN pattern, and if immunofluorescence is negative, okay, in addition to that, if you go to high magnification, you find these cells. You see these lymphocytes. These are the lymphocytes which are lying inside the glomerular capillary loops. Okay. So what you're seeing here is this is a mesangial area. So mesangial area is showing some expansion with mesangial hypercellularity. So when I say mesangial hypercellularity, there has to be more than four nuclei in the mesangial. And just see, just compare this capillary wall with this capillary wall. So this capillary wall appears thicker than this one. Okay. So that is called as a non-uniform thickening. Okay. In addition to that, you are finding lymphocytes within the capillary loops. In a native kidney biopsy, if you find lymphocyte within the glomerular capillary loops, you label that as endocapillary proliferation or endocapillary hypercellularity. But in a transplant setting, if you find lymphocytes within the glomerular capillary loops and you feel that it is not an immune complex mediated disease, it is a chronic AMR kind of a thing, then you label it as glomerulitis. So presence of inflammatory cells within the glomerular capillary loops is called as glomerulitis in a transplant setting if we are going to give a final diagnosis as chronic AMR. However, in a native setting, presence of inflammatory cells within the glomerular capillary loops is called as endocapillary hypercellularity or endocapillary proliferation. You can also appreciate this globally sclerosed glomerulus. These are the vessels which are thickened. There is segmental sclerosis. There is some mesangial hypercellularity, and these are peritubular capillaries, which shows that there is peritubular capillaritis. Now, just compare the thickness of the tubular basement membrane with the PTC. Normally, PTCs are very thin wall. If you see a PTC which is very thick wall, look at the thickness of the PTC. It is of very similar thickness as the tubular basement membrane, slightly less thickened than tubular basement membrane. Normally, PTCs are very thin capillaries. They will not be visualized on light microscopy. So you have to go to high magnification to look at a PTC. So at high magnification, if the thickness of the PTC is similar to that of tubular basement membrane, that suggests that this PTC is showing thickened walls. And if you do electron microscopy on this PTC, you'll find PTC multilayer. So what you can appreciate here is this PTC showing these cells, which is like 1 lymphocyte, 2, 3, 4, possibly 5. So there is PTC capillaritis which is there. This is a proximal tubule. Okay, this is most likely a distal tubule, and you are finding this kind of a PTC capillaritis. Okay, so there are some vessels which are showing evidence of hyalinosis also. So this is a small vessel which is showing evidence of hyalinosis with narrowed lumen. Similarly, this entire thing is a vessel which is showing smooth muscle hyalinosis. So smooth muscle hyalinosis, it is not a very specific morphological findings which you see in chronic CNA toxicity. Many times if you find smooth muscle halitosis and there is ATN, we raise a possibility that this could be due to CNI toxicity. But always remember that smooth muscle halitosis can be seen in any long-standing hypertension also. It can be seen in diabetic nephropathy also. So always remember, presence of smooth muscle halitosis alone doesn't mean that it is a chronic CNI toxicity. So in this case, since there is glomerulitis, since there is PTC capillaриtis, since we are seeing some non-uniform thickening of the glomerular capillary wall, if you look at the C4D, C4D was showing some minimal staining in the peritubular capillary. This is a C4D immunohistochemistry, but this is a C4D immunofluorescence. And C4D immunofluorescence shows that there is thickening of the glomerular capillary wall, which is there. Sorry, not thickening. There is staining of the glomerular capillary wall. In addition to that, there is PTC staining also. So presence of staining in the peritubular capillaries as well as glomerular capillary wall staining suggests and confirms that possibly we are dealing with chronic antibody-mediated process or chronic antibody-mediated rejection. A most important thing is before we label this as chronic AMR, we have to say that immunofluorescence is completely negative. There can be non-specific IgM trapping or C3 trapping, but there should be no IgG, IgA, there should be no C1q and all that. There could be non-specific trapping of immunoglobulins. That most common immunoglobulin which gets trapped is IgM, and the most common complement which gets trapped is C3. Even C1q sometimes can show trapping. So always remember immunofluorescence has to be negative. If you find a morphology which is like transplant globulopathy, and transplant globulopathy means that there is thickening of the glomerular, non-uniform thickening and duplication of the glomerular capillary wall. I'll highlight duplication of the capillary wall in the next case also. Other thing is, we did albumin staining also because if you go through the history, it is mentioned that this patient has long-standing diabetes, has diabetes for some duration and uncontrolled diabetes. So albumin staining is also there. And I showed you that there is some mesangial expansion. So there is a possibility that there could be coexistent diabetic component also which is going on. But diabetic component will not explain the non-uniform thickening and duplication. Diabetic nephropathy will not be able to explain the microvascular inflammation, that means the glomerulitis and the PTC capillaриtis. And diabetic nephropathy will not be able to explain the C4D staining in the peritubular capillaries and along the glomerular capillary. Now, we did electron microscopy also in this case. So in electron microscopy, what you are seeing is, this is the original glomerular basement membrane, and there is a new GBM which is being formed. So this is a new basement membrane which is being formed. So whenever there is so whatever duplication you are seeing on ultrastructure examination or on electron microscopic examination, what you find is this is one membrane like this, and this is a second membrane like this. So this is first membrane, first GBM, and the second one is a new GBM or new glomerular basement membrane which is formed. And in between area is showing mesangial matrix. Okay, so this is what you see under light microscopy as duplication of the glomerular capillary wall. So when you find this kind of a thing and there is absence of any immune complex deposit, so this morphology, this ultrastructure morphology is consistent with only two pathologies. First is chronic antibody-mediated rejection, and the second pathology is chronic thrombotic microangiopathy. On electron microscopy, chronic TMA and chronic AMR will look similar, the glomerular morphology. The only difference will be on electron microscopic examination, chronic AMR will show peritubular capillary basement membrane multilayering, whereas peritubular capillary multilayering will not be seen in chronic thrombotic microangiopathy. That is the only difference. Otherwise, on morphology, obviously, we will see microvascular inflammation, which will not be seen in chronic TMA, which will be seen only in chronic AMR. So in this case, the diagnosis is chronic AMR with coexistent early diabetic nephropathy. Why we are labeling there is a coexistent early diabetic nephropathy? Because we have seen that some glomuli, they were showing mesangial matrix expansion. The other thing is that we have also seen that there is albumin staining also, which is there. Okay, so presence of albumin staining with mesangial matrix expansion suggests that there is a coexistent early diabetic nephropathy. I also showed you one FSGS lesion. Always remember, in a transplant setting, if there is a FSGS lesion, we should not jump to a conclusion that we are dealing with FSGS, recurrent or de novo kind of FSGS. because this patient had proteinuria also. Always remember in a transplant setting, FSGS could be due to n number of reasons. The most common cause for secondary FSGS lesion in a transplant setting is chronic antibody-mediated process. So chronic AMR can produce FSGS lesion. Long-standing hypertension, long-standing diabetes can produce FSGS lesion. Even chronic CNA toxicity can produce FSGS lesion. Okay, so we need to look. If there are 10 glomeruli, there is one glomerulus which is showing FSGS lesion. We have to look at the other glomeruli. If other glomeruli are showing thickening of the glomerular capillary wall, duplication, uh, glomerulitis, PTC capillaritis, we have to consider a possibility of chronic AMR. And we should say that it is chronic AMR with secondary FSGS lesion rather than labeling that as a podocytopathy, which will be an incorrect diagnosis. The other thing is we have also seen, so I'll show you the previous images. So we have also seen like this case, you can see these podocytic foot process projection. So there is preservation of podocyte foot processes at areas. Always remember chronic AMR or any kind of MPGN also, even cases of membranous, recurrent or de novo, they will show foot process effacement. So if there is a reason for podocytic foot process effacement, like in this case, there is underlying chronic AMR, then we should not consider a possibility of primary podocytopathy. We should say that this amount of podocytic foot process effacement is likely related to underlying chronic AMR, and it doesn't suggest that there is a coexistent primary podocytopathy which is occurring in this patient. So I'll show you another case. This was a 29-year male. This patient had hypertension, and in 2004, he had biopsy-proven FSGS also. So we don't know whether this FSGS was due to hypertension or whether this FSGS was a primary FSGS. Obviously, electron microscopy was not done during this time. So this patient underwent renal transplant in 2007. This is an old case. So in 2009, the first biopsy was done, which was reported outside as IFTA, and electron microscopy was done on the same biopsy in 2009, which was in which a possibility of podocytopathy was raised, possibly recurrent. And since there was a history that that this patient was a biopsy-proven FSGS, so it was thought that this patient, after 2 years, he had some proteinuria also. So it was thought that it is possibly a recurrent podocytopathy which is occurring. And now, after that, after 2009, from 2009 to 2012, this patient has progressively rising serum creatinine and proteinuria, and the present creatinine in 2012 was 2.6, and the proteinuria was 10 grams. So repeat biopsy was done in 2012. So this was like periodic 5 weeks. So if you look at this biopsy, what you can see is this is a PS chain. We can see one globally sclerosed glomerulus, another globally sclerosed glomerulus, another globally sclerosed glomerulus, one more globally sclerosed glomerulus. So that means that this patient, out of maybe 6 glomuli, 4 are globally sclerosed. Okay. Now, if you look at these tubules also, which I'll show in the higher magnification. So I will go to a higher magnification. We can appreciate this is a globally sclerosed glomerulus, and you can see these 3 non-sclerosed glomuli. I'll show a higher magnification of a few of these glomuli. Now, there was one glomerulus which was showing. Why I'm saying segmental sclerosis is look at these capillary loops. You can see absolutely patent looking capillary loops. They are empty looking, okay? And just compare this area. This area, there is complete loss of patency of these capillary loops. And you are seeing there is some extracellular protein deposition. So this is called as segmental sclerosis. So there is FSGS lesion, but now we have to look at the other area of the glomerulus which are non-sclerosed. So other area of the glomerulus, we are seeing these lymphocytes within the glomerular capillary loops. So presence of lymphocyte within the glomerular capillary loops, that suggests evidence of endocapillary hypercellularity, or in a transplant setting, if we are considering a possibility of chronic AMR, then we have to label this as glomerulitis. Now, another glomerulus, you can see, just appreciate that there is this glomerular capillary wall, and just look at this capillary wall. So this capillary wall is showing duplication. You can see a clear space, a whitish appearing space between in this capillary wall. Okay. Also, you can see a duplication which is seen here. you can see spacing between the two capillary walls. So if you find spacing, so morphologically it is transplant glomulopathy, and always remember here also you can find that clear space. Always remember transplant glomulopathy is a morphological term. Okay, transplant glomulopathy doesn't mean it is chronic AML, because transplant glomulopathy by definition means that there is a non-uniform thickening and there is duplication of the glomerular capillary wall. And transplant glomerulopathy, like morphology, can be seen in chronic AMR, can be seen in chronic TMA, can be seen in immune complex mediated MPGN. So that means all entities which can show non-uniform thickening as well as duplication of the glomerular capillary wall. So the all the differentials should be considered whenever we label anything as transplant glomulopathy. So if a pathologist says transplant glomulopathy, please don't consider that as chronic AML, because there could be n number of reasons with this kind of a morphology. Even a chronic CNI toxicity can produce chronic TMA, or chronic hypertension can produce chronic TMA, and that morphology will be of transplant glomulopathy. That means duplication of capillary wall. Now look at the PTCs. Now just compare. This is a proximal tubule. Okay, this thing is a proximal tubule, and look at the thickness of the tubular basement membrane. And this is the peritubular capillary. So peritubular capillary thickness is more than the thickness of the tubular basement membrane. Also, you can find one lymphocyte here. Similarly, this is also a PTC. You can find one lymphocyte, a second lymphocyte here. Similarly, this is a PTC. You can find one, two, and possibly this is the endothelial cell. So there is some PTC capillaritis which is there. Immunofluorescence showed only renal medulla. Immunohistochemistry C4D was negative. Always remember, negative staining for C4D in the peritubular capillaries in chronic AMR can be seen in 40 to 50% of cases. Okay, so based on negative C4D staining, we can't rule out possibility of chronic AMR. Okay, we did ultrastructure examination also. This is just for comparison. This is the normal uh, glomerulus under ultrastructure examination, how it looks like. So what you can appreciate is, so this is the GPM, and what are these projections are food processes. Similarly, you can see these projections. All these are food processes. So this glomerulus is a normal glomerulus which is showing absolutely preserved food processes. Now I'll show you the pathological glomerulus. The glomerulus of the case, what I have just shown you the morphology, just before the slide. So you can see that this is the original GPM, and there is a new GPM which is being formed here. Similarly, you can see a GPM here. There is a GPM which is formed, a new GPM, and another membrane which is formed. So there is glomerular basement membrane multilamination. So if you find multiple layering of the glomerular basement membrane, that is a common finding you see in chronic antibody-mediated process. This is a high magnification. You can see the GPM which is seen here, and you can see a new GPM which is being formed here. And what you are seeing here is all mesenchymal matrix which is coming in these two new GPMs. Mesenchymal matrices is filling up the space between the two GPM. So what you see under light microscopy as duplication, and this is what you see under ultrastructure examination. So there will be GPM multilayering, there will be GPM multilamination. In addition to that, when you look at the peritubular capillary, this is a low magnification of peritubular capillary. Look at this PTC. So there are multiple layers. You can see 1, 2, 3, maybe possibly 4, 5, or 6. So if you find 5 to 7 layers or more, one PTC with more than 7 layers under ultrastructure examination, that is consistent with a chronic antibody process. Okay, so this case is not showing C4D staining, but it is showing duplication. It is showing evidence of transplant glomulopathy. It is showing some minimal microvascular inflammation in form of glomerulitis and peritubular capillaritis. It also showed a FSGS lesion, which is a secondary FSGS lesion. So similarly, just see this. So you see multiple layers of PTC, peritubular capillary basement membrane multilayer. This is a classical finding you see in only chronic AMR. So morphologically, the glomerular morphology where you find GPM multilamination can be seen in chronic TMA also. But if you find PTC multilayering, along with the glomerular morphology, what I have shown you, GPM multilamination, then you have to label it that as a chronic antibody-mediated process. But if you If you find only GPM multilamelation or GPM multilayering, if you find some fibrin deposition also and no PTC multilayering, then you can raise a possibility that this is possibly chronic TM. But remember that there should be no C4D stain, there should be no microvascular inflammation in light microscopic examination. So we reviewed the first biopsy also, the electron microscopy. So electron microscopy, when we reviewed the first biopsy, uh, it was seen that majority of the food processes were fine, but there were areas where the food processes were completely effaced. Like in this area, just look at this area of the GPM where the food processes are seen, and look at this area of the GPM, but where food processes are not seen. So focal food process effacement, if it is there, that doesn't mean that it is a primary podocytopenia. So focal food process effacement, focal podocytic food process effacement can be seen in chronic AMS. Now, as compared to the second biopsy, electron microscopy, the first biopsy showed just a minimal kind of subendothelial expansion. Always remember that early changes of chronic AMR can be picked only on ultrastructure examination. Okay, so the first biopsy EM was also not consistent with primary podocytopathy. It was more like a early chronic AMR. Okay, so it is a chronic antibody-mediated rejection with secondary FSGS lesion. There is no evidence of recurrent or de novo primary podocytopathy. So before going further, I just want to highlight what you see in acute antibody-mediated rejection. So acute antibody-mediated rejection, everything is acute. So you find the first thing acute you'll find is there is acute tubular injury. So all the tubules are dilated. If you see here, so tubules are dilated. You can see the brush border which is getting disrupted, which is lying within the lumen. Okay. If you look at the tubular nuclei, these are the tubular nuclei which are there. Okay. You can see these tubular nuclei, and at places there is disruption of the tubular nuclei also. They are lying within the lumen. So there is diffuse acute tubular injury. This is a distal tubule, and this is a proximal tubule. So proximal tubule has brush border. So you will see loss of brush border. In glomerulus, you will find acute changes in form of mesangial. You hardly see any mesangium. And what is happening is all because mesangium is like a supporting medium for the glomerular capillary loop. So when the mesangium is undergoing lysis, there is no support for glomerular capillary loops. So glomerular capillary loops get dilated. Okay. And what you are finding is fibrin within the glomerular capillary loops. You can also see some inflammatory cells within the glomerular capillary loops, that is glomerulitis. Mostly in acute AMR, you will not find lymphocytes, you will find more neutrophils, but even lymphocytes can be seen. So if you find mesangial, if you find fibrin thrombi, these are the findings you get to see in acute thrombotic microangiopathy. Along with that, if there is microvascular inflammation in form of glomerulitis with presence of neutrophils, this glomerulus also show this is H&D stain where you see a lot of congestion of the glomerular capillary loops, but majority of the glomerular capillary loops are filled with fibrin. So this is like a acute TM. In addition to that, if you look at the peritubular capillaries, there is neutrophilic peritubular capillaries. So all these findings suggest it is acute antibody-mediated rejection. In addition to that, if you look at vessels, there could be evidence of vascular rejection. So when we say vascular rejection, mostly in acute antibody-mediated rejection, the intensity of vascular rejection is slightly towards the higher side. So you will find V2 or V3 lesions. Even V1 lesions can be seen, but commonly you get to see V2 and V3 lesions. Similarly, here you can see that the inflammatory cells are seen throughout the wall of the vessel. This is called as a transmural infiltrate or transmural arteritis or V3 lesion. Okay. A C4D will be positive, diffusely positive, and this is the IHC, which is also showing C4D positive. So what happens in chronic AMR? So whatever I have shown in acute AMR, that means TMA, mesangiolitis, neutrophilic glomerulitis, neutrophilic peritubular capillaris, ATN. In chronic AMR, what you find is in glomerulus, you'll find transplant glomerulopathy, which I've shown you first two cases. MPGN kind of a pattern, you find duplication of the capillary wall trans. So in the glomerulus, you'll find transplant glomerulopathy. In the tubules, you'll find atrophy. That means chronic changes in the tubules, that is atrophic tubules. In the interstitium, instead of interstitial edema, you'll find interstitial fibrosis. In other words, the previous terminology before 2005 was CAN, chronic allograft nephropathy, CAN. Then it was replaced by IFTA, interstitial fibrosis and tubular. So if with transplant glomerulopathy you find IFTA, okay, these are the findings you get to see in chronic AMR. In addition to that, I've shown you endothelitis or active vascular rejection in acute AMR, whereas in chronic AMR you find intimal sclerosis. So you'll find a chronic vascular rejection. So this is a Mason Strachan stain, which shows that this green color is all IFTA. Sometimes you'll find blue color. It all depends. Different labs use different colors. So there could be commonly you see blue color in Mason Strachan stain. And this is a PS stain, which shows that these tubules are completely atrophic. They are small sized tubules with no lumen. And just compare these tubules with these tubules with a dilated. So there are atrophic tubules and the adjoining tubules, they are working more. So that is why there is a compensating enlargement of the tubules you can visualize. This is just a morphological triad of chronic AMR. So what you find is in the glomerulus, you find double contours or transplant glomerulopathy. In the tubular interstitium, you find IFTA. In the vessels, you find intimal sclerosis. This is a true lumen of the vessel. This is completely narrowed down, okay? And there is the intimal sclerosis. This complete thing is a intimal sclerosis. In the under the ultrastructure examination, I have shown you there will be GPM multilamination, and PTC will show multilayering, and C4D can be positive. But always remember, chronic AMR cases, around 50% cases, they can be negative for C4D, but still it is chronic AMR. This is just to highlight this when you look at the CG scoring of chronic glomerulopathy score in transplant glomerulopathy. Sometimes the CG score is divided into 1A and 1B now, but CG score 1 means that there is no significant or definite duplication. You can find some thickening of the capillary wall, non-uniform thickening. When I say non-uniform thickening, just compare this capillary loop, okay, with this capillary loop. It seems that there is some early kind of duplication which is starting, but it is not that evident. But if you look at a slightly advanced case of transplant glomerulopathy, you'll find just compare this capillary loop with this area of the capillary loop, you will find absolutely there is a clear space which is there. Okay, so that means there is a duplication. Uh, do remember that normally whenever we interpret duplication, we interpret mostly in the peripheral capillary loops and not inside the capillary loops. But even central area of the capillary loops can be interpreted. And this is at very advanced transplant glomerulopathy. What you are seeing is clearly you can see one membrane here and one membrane here. In between, there is a clear space. So this was also labeled as a tram track appearance and all that stuff. So, and in addition to that, you can find some inflammatory cells within the glomerular capillary. So these are the findings of glomerulitis. You can also see a clear space here. You can see a clear space, whitish space, a whitish space here. Okay. So all these findings suggest that there is this is all transplant glomerulopathy, and this is consistent with chronic AMR because we are seeing glomerulitis also. And this is a silver stain, which further highlights that there is evidence of duplication of the capillary. You can see these clear spaces within the GPM. Similarly, here also you can see a duplication of the glomerular capillary. Okay. And there are lymphocytes which are there. So all these findings suggest, and PTCs I've shown you, thick walled PTCs. And in the vessels, this is a Mason Strachan stain. Vessels are showing intimal sclerosis. So presence of chronic sclerosis with all those findings, immunofluorescence has to be negative. Always remember, in a transplant setting, if there is proteinuria, we need to do immunofluorescence in all cases, and we need to do electron microscopy also. And immunofluorescence is negative for all immunoglobulins and complement, and C4D is positive. So these findings, and C4D, normally C4D is seen in the mesangium, but if you find C4D along the glomerular capillary wall or glomerular capillary loop, that is consistent with chronic antibody-related process. I've shown you this before. What I want to highlight is whatever duplications you are seeing here, and this is what on ultrastructure examination you see multiple layers of GPM. Always remember, in light microscopy, you use term capillary wall, but in ultrastructure examination, you use a terminology GPM. So don't use the terminology GPM in light microscopic examination. Never say the light in the light microscopy, pH stain shows increased thickening of the glomerular basement membrane. Just say PAS stain shows increased thickening of the glomerular capillary wall. GBM terminology should be restricted only to ultrastructure examination or electron microscopic examination. I've shown you PTC multilayering. So I'll come to another case. 22-year female, basic disease for CGN and ABO incompatible transplant. This was done in 2012. Old case, planned for protocol biopsies. Those days, like it was like ABO incompatible transplant just started. So we were doing protocol biopsies. So 3 months post transplant, the urine protein was 3 plus and RBCs were 10 to 12, 3 months post transplant. 24-hour urine protein was 3 grams. Serum creatinine was fine, 1.2. So the possibility of recurrent GN was considered. Now look at this morphology. You can see these glomuli which are there. There is hardly any interstitial inflammation. So you can see these glomuli. I'll show high magnification of these glomuli, but even at this magnification, you see that these glomerular capillary loops, they are filled with certain cells, okay, which I'll show in the high magnification. So if you go to high magnification of this glomerulus, what you are seeing is you are finding neutrophils in the glomerular capillary loops. So now if you find neutrophils in the glomerular capillary loops, you might say that, okay, so this is neutrophilic glomerulitis, okay? But remember that before labeling this as neutrophilic glomerulitis, you just see, is there any thrombotic microangiopathy? Is there any mesangiolisis at this glomerulus? So there is no mesangiolisis. There is no thrombotic microangiopathy, and the creatinine is absolutely fine. So the predominant problem is proteinuria, which is 3 grams. So what you are seeing on morphology, there are neutrophils which are there. And this is a pH change which further shows there are neutrophils which are there. So the morphology is like a diffuse proliferative because all the glomerular capillary loops are showing endocapillary neutrophils. Okay, this is the ABO compatible transplant. C4D was positive, and that was related to accommodation. So morphologically, it is a diffuse proliferative glomerulonephritis. What is the next step? We need to do immunofluorescence. Okay, immunofluorescence IgG, IgM is negative. Okay, so likely possibility is it is not an immunoglobulin driven lesion. Okay, but C3 was positive. C1q was negative. So it suggests that there is a diffuse proliferative glomerulonephritis, which is neutrophil rich, and you are finding C3 only. We did ultrastructure examination, we did EM, and EM shows presence of these neutrophils, which we were seeing in light microscopy also, which are filling the glomerular capillary loops. This is the Bowman's capsule. This is a glomerular capillary, glomerular basement membrane, and you are finding this kind of a hump-like deposit. I'll show high magnification. So you can see these are the neutrophils within inside of the glomerular capillary loops. There is a hump-like deposit like this. This is a high magnification of hump-like deposit. So presence of hump-like deposit with endocapillary neutrophils, the first thing which comes to your mind is whether I'm dealing with the infection-related GN because there are subepithelial humps with neutrophils. So the differential diagnosis considered was whether it is an infection-related glomerulonephritis, and the second possibility was whether it is C3 glomerulonephritis. This was a young female, and we don't know the basic disease. It was CGN, and there was no history of any infection in this patient. Okay, so previously, like in 2012, this was an old case. We used to label them as post-infectious glomerulonephritis, but actually now we know that we hardly label them as post-infectious. We always say it is an infection-related GN. Okay, so but morphology is like a diffuse proliferative glomerulonephritis with only C3 deposits and electron microscopy showing the subepithelial hump. So all these findings are pretty consistent with the infection-related GN. Now, a repeat biopsy was done 6 months post-transplant because this patient had persistently low C3. The urinary sediment was still active, and the proteinuria progressed from 3 gram to 6 gram. But the serum creatinine was absolutely same, which was there 3 months back. So serum creatinine 3 months post-transplant was 1.2, and 6 months post-transplant also it is like 1.2. Now the repeat biopsy, if you look at the repeat biopsy, what I've shown you, a MPGN pattern. Look at this. There is a space between the glomerular duct. So there is some lobulation of the glomerular duct, which was not seen in the first biopsy. Always remember, If the biopsy is done early during the course of any disease, which is a MPGN kind of a disease, or when I say MPGN kind of a disease, you know that I'm talking about a C3 globulopathy. So in a case of C3 globulopathy, if a biopsy is done early during the course of the disease, you may find only a diffuse proliferative glomerular morphology. Always remember, MPGN always occurs due to chronic kind of a process. It is a chronic process due to chronic antigenemia, or due to chronic endothelial injury, or due to persistent chronic endothelial injury. Okay. Now, there was presence of one cellular crescent also, which was seen here. So this is a pH chain which shows the underlying glomerular duct is completely compressed. And what we are seeing is this is a Bowman's capsule. What you are seeing is this all crescent. So this is called as a global crescent. So there was one global cellular crescent, and majority of the remaining glomuli showed lobular accentuation. So there's a high magnification of the lobular accentuation. You can see endocapillary hypercellularity. You can see the mesangial matrix expansion with mesangial hypercellularity. You can see lymphocytes. Now you are not seeing neutrophils. You are seeing more lymphocytes because it is now a 6 months post transplant. This is just for comparison. The first biopsy was showing more neutrophils, but less of lobular accentuation. The second biopsy is showing more lymphocytes and more of a C3, only isolated C3 deposits were there. This is the second biopsy. And C4T was positive. As we know, this is a APM compatible transplant. So morphologically, there was no TMA. There was no peritubular capillaritis that we raise a possibility that this could be acute antibody mediated process. Uh, and we did now EM on the second biopsy, and EM on the second biopsy showed that there were presence of these mesangial deposits as well as some hump-like deposits. So you can see these mesangial deposits which are there, and there were some subendothelial deposits also which are there. So presence of mesangial subendothelial deposits and occasion hump-like deposit suggests that possibly we are dealing with a C3 glomerulonephritis. Why I'm not saying C3? Why I'm not saying dense deposit disease? Because dense deposit disease should replace entire GPM. By dense, we're replacing the entire glomerular basement membrane. What we are seeing is deposits in the mesangium area, some small deposits in the subendothelial space. That is why we label this as C3 glomerulonephritis, and de novo in a ABM compatible renal transplant. And as we know that distinction between C3 glomerulonephritis and dense deposit disease can be done only on ultrastructure examination. So based on immunofluorescence and light microscopy, you can only label this as C3 globulopathy, recurrent or de novo. But only on ultrastructure examination, you will be able to say, yes, it is C3GN or whether it is a DDT. So as you can say, this area, this is another case, dense deposit disease. So you can see dense osmophilic deposits, which are replacing the entire glomerular basement membrane. Okay. And you look at the color of the deposit, they are extremely electron dense, they are extremely dark. Now, if you compare DDT with this C3 glomerulonephritis, you don't see so dense deposit. You see some waxy kind of amorphous deposit which are there in the mesangium as well as along the GBM. Even a C3 glomerulopathy, glomerulonephritis can show intramembranous deposit, but they will not be that electron dense what you see in a triple D disease. And we know that C3 glomerulopathy masquerading as a acute post-infectious glomerulonephritis, it is not an uncommon thing. So always remember, it all depends what stage you are biopsying this patient. If the biopsy is done early during the course of the disease, you may interpret that as an infection-related GM. So C3 glomerulopathy, as we know, it is a proliferative pattern of glomerulonephritis, which is characterized by complement deposit that stain solely or dominantly for C3. A subset of cases of C3 glomerulonephritis have features that overlap extensively with acute post-infectious glomerulonephritis. And as a clinician and as pathologists, we should be aware that similar findings can be seen in both these conditions. So we go to another case. So this is a 42-year male renal transplant in 2010. Baseline creatinine is 1.1. The present there is rise in serum creatinine. Along with that, there is proteinuria. Now, if you look at this biopsy, it is showing more chronic changes in these areas, but there is some infiltrate also. There is a globally sclerosed glomerulus, and these are the non-sclerosed glomeruli you can see here. So these are the non-sclerosed glomerulus, glomuli. So I'll show high magnification. If you look at the high magnification, you find that there is some thickening and occasional capillary loop, which is showing a very segmental duplication also. But it is not showing any endocapillary proliferation. It is not showing any glomerulitis or endocapillary hypercellularity. So practically, there is just few glomerular capillary loops which are showing the segmental kind of duplication. There is minimal thickening of the glomerular capillary wall, which is there. There was some interstitial infiltrate, and you can see these tubules with evidence of lymphocyte within the tubular basement membrane. That suggests there is mild tubulitis. So there is a borderline cellular rejection. C4D was negative, but what we could appreciate was that there is some IgG granular staining along the glomerular capillary wall. Now, if you look at kappa lambda showed lambda, which was like 3 plus, and kappa, which was negative in these glomeruli. So this is a globally sclerosed glomerulus. So if the biopsy showing immunofluorescence score is showing predominantly globally sclerosed glomerulus, there is a possibility that immunofluorescence can be negative. So we need, as pathologists, we need to interpret immunofluorescence in non-sclerosed glomeruli. Okay. So in the non-sclerosed glomeruli, kappa is negative, but lambda is like 2 plus 2, 3 plus staining, which is. So it is like, so this was an old case 10 years back. So that time we thought that it could be either MGRS and all that stuff. And this patient developed lymphoproliferative disorder later on, maybe after. So this was the initial kind of presentation. And after 2-3 months, the PET scan findings showed that there was extensive lymphadenopathy and the lymph node biopsy was reported as lymphoproliferative lesion. So what I want to highlight is it is very important. Many times we believe that there is no need of doing kappa lambda in transplant biopsies. Even some places, even native biopsies, people say that this is the patient is young age and we should not. There is no need of doing kappa lambda. Kappa lambda should be done in all biopsies, whether it is native or transplant, because you are going to pick up lesions. So we are able to pick up MGRS entities only because we are routinely doing kappa lambda in all cases. I remember there now, in the last 4-5 years, we have picked up MGRS in a transplant setting. Basic disease is CGM, and you see that there is a proliferative GN with monoclonal IgG deposits in a transplant biopsy, and that too like 2-3 months post-transplant. Okay, so it is important that we do kappa lambda in all these cases. So this was membranous glomerulonephritis different. What I want to highlight in this case is you can even an advanced membranous can show duplication of the capillary wall, which can give you an impression that there could be an MPGN pattern. So MPGN pattern can be seen in advanced membranous. So another case, 56 a male post-transplant, 2015, POD 2 years, now proteinuria for 1 month. Basic disease was crescentic GN. Urine routine microscopy showed 3 plus protein and UPCR was 5.6. Serum creatinine was fine. So always remember, many times we say chronic AMR, serum creatinine has to be towards higher side. Not all cases will show increased serum creatinine. Sometimes chronic AMR can present only as isolated proteinuria, okay, rather than rising serum creatinine. So this was a case like that. This is POD2 here. And what you this is a silver stain which shows that there was evidence of lymphocytes within the glomerular capillary loops. I won't say there was a significant duplication, but yes, this area was showing a very minimal duplication. So it was like a CG1B, a very early kind of a transplant glomerulopathy with evidence of mild microvascular inflammation. C4D was showing positivity in the peritubular capillaries. So that means surely we are dealing with a chronic AMR. The only problem was the patient had significant proteinuria, UPCR 5.6. But this kind of a morphology, there was no significant glomerulosclerosis. Even the transplant glomerulopathy was more like an early transplant glomerulopathy. It was not a very advanced transplant glomerulopathy. When we score the transplant glomerulopathy as CG1, 2, 3, it was like fitting more into a CG1B kind of a, so that means early kind of a chronic glomerulopathy score. So morphology was not, I was not able to explain the 5.6 gram proteinuria with this kind of a morphology. We did C4D by immunofluorescence. C4D was positive, so that confirms that surely we are dealing with early chronic AMR. But we did other stains also. So we did IgG. IgG showed some fine granular staining along the glomerular capillary. Always remember, since these patients are on immunosuppressive therapy, transplant patients, you will not find very strong kind of 3 plus staining with IgG if you are dealing with a membranous case. The staining will be slightly towards the lower side because these patients are on immunosuppressive therapy. So the staining could be 2 plus also. But you, as a pathologist, we have to train our eyes that even we are able to pick up the early kind of membranous, which is there, or which is showing the minimal kind of IgG staining. We did IgG subclasses also. The IgG subclass also show more IgG4 than IgG1. IgG2 and 3 was negative. Kappa lambda was showing equal staining. There was no light chain restriction. PLA2R was negative. We did electron microscopy. Electron microscopy, this is a GPM. Okay, so electron microscopy show presence of these subepithelial deposits, which are there. In addition to that, this is a true GBM, and you are seeing subendothelial expansion. Presence of subendothelial expansion could be a manifestation of early chronic AMR. So, with early AMR, early chronic AMR, I would say that you are also seeing evidence of membranous deposits. Okay, so what is the possibility? You can consider two possibilities. Either there is early chronic AMR with coexistent membranous. Now we did PLA2R, that is negative. PLA2R serum anti-PLA2R antibodies were also negative. Remember that 1 year post-transplant, if patient has proteinuria and you are finding chronic AMR, this chronic AMR can lead to de novo membranous cells. Okay, so always remember that, and this patient, DSA was done, the DSA, class 2 DSA was like, it showed around 15,000 MFI. And this patient underwent plasmapheresis. Immediately after 1 or 2 or 3 sessions of plasmapheresis, the proteinuria settled. So that means the proteinuria was related to antibodies. Okay. So all these antibodies, they cause damage to the podocyte antigen, which leads to formation of de novo membranous. So chronic AMR with de novo membranous glomerulopathy. Now, when you have to make these kind of diagnoses, you require immunofluorescence as well as ultrastructure examination or electron microscopic examination. Otherwise, you will miss some of these diagnoses. Now, this is another case. I just want to show you some images that this glomerulus is mostly sclerosed. This is a pH chain. It is a sclerosed glomerulus like this. So majority are sclerosed. There is good amount of superficial chronicity. This is a transplant biopsy, but few non-sclerosed glomeruli showed that there is thickening of the Bowman's capsule, but there is mesangial matrix expansion and thickening of the glomerular capillary wall. Okay. So with mesangial matrix expansion, thickening of the glomerular capillary wall, if you find albumin staining, non-specific IgM, trapping and all that, always consider possibility of diabetic nephropathy. Many times there is a history that there is no DAT. Sometimes the basic disease is diabetic nephropathy. So remember that even diabetic nephropathy can show MPGN pattern like in this case. There is mesangial expansion, there is macular thickening. You can also find duplication. Now, this case, this is like a classical transplant glomerulopathy. You are finding extensive duplication of the glomerular capillary wall. You can see two membranes. You can see this area, extensive duplication of the glomerular. This is a silver. This is a GMS stain. It shows extensive duplication of extensive duplication of the glomerular capillary wall. In other words, it looks like a CG3 duplication of advanced chronic glomerulopathy. C4D was negative in the PTCs as well as in the glomerular capillary wall. There was non-specific IgM and C3 trapping in these areas where there was duplication. Now, with this kind of a morphologies, if immunofluorescence is negative, when I say immunofluorescence is negative, that means immunoglobulins, IgG, IgA IgM is non-specific trapping. Kappa lambda is not showing any restriction. There is a C3 which is there, which is only non-specifically deposited. Uh, Consider NC40 is negative. There is no microvascular inflammation, so no glomerulitis, no PTC keratitis. These cases you can consider that them as chronic thrombotic microangiopathy. Always remember chronic TMA and chronic AMR. The glomerular morphology is very similar. The only difference is you will find microvascular inflammation, or you will find microvascular inflammation in chronic AMR, which you will not find in chronic thrombotic microangiopathy due to chronic hypertension or chronic CNI toxicity. The other thing is you will not find, if you do electron microscopic examination, you will not find PTC multilayering, extensive PTC multilayering in chronic TMA, but you will find extensive PTC multilayering in chronic antibody-mediated rejection. This was a recent case. This also showed a MPGN kind of a pattern, and this was a fibrillary GL post-renal transplant. This patient also, the basic disease was not, it was like a CGN, or it was labeled as a membranous. So what happens in fibrillary, you find a smudgy IgG staining, and smudgy IgG staining is interpreted as membranous. Remember, membranous will show granular IgG staining, whereas fibrillary will show a smudgy IgG staining. That is the difference. And obviously, you can do DNA JB9 to prove that it is fibrillary. And obviously, we can do electron microscopy examination also for confirmation of fibrillary. So, what I want to highlight is even a fibrillary GM can show MPGN pattern, but this is not a common thing. I've shown you common entities. I haven't shown you IgA, but remember that IgA can also show a MPGN pattern. Chronic TMA can show a MPGN pattern. Transplant glomerulopathy or a chronic AMR can show MPGN pattern. So, uh, and fibrillary diabetic nephropathy can show MPGN pattern once. So, now if immunofluorescence is positive, then you can think a possibility that morphologically it is MPGN and you're finding IgG and C3 and no light chain restriction. Then you can consider possibility of immune complex mediated MPGN also in a post-transplant setting. But I must tell you, I've never seen a MPGN, immune complex mediated MPGN recurrence in a post-transplant. The common things what you see post-transplant setting is IgA. You may find membranous, okay, but you will not find MPGN. Yes, as I've told you, proliferative GN with monoclonal deposits we are seeing now cases post-transplant. So what I want to highlight is the take-home message is definite categorization of the glomerular lesion in post-renal transplant requires immunofluorescence and ultrastructure examination or electron microscopy. Transplant glomerulopathy is just a morphological term, just like MPGN. Okay, don't consider if someone says transplant glomerulopathy, it is not synonymous with chronic AMR. Okay, EM morphology of chronic TM and chronic AMR is similar except for PTC button. So this was my last slide. So if there are any questions or any queries, you can always ask. So you can write in the chat box also if you want to see. So there is a query. There is a DSA positivity criteria in the diagnosis of ABMR. Usual reports from Lal Path Labs with DSA, HLA, A, B, DR. Is this enough or should we do SAP? See, I must tell you that I am not a transplant immunology kind of a person. I'm more of a transplant histopathologist. So I'm not the best person to uh, tell you this thing. Uh, So chronic TMA, any specific finding in arterioles other than Yes, absolutely. So whenever we see chronic TMA, mostly we see chronic TMA in a setting of chronic CNI toxicity and chronic uncontrolled hypertension. So obviously, if it is in a setting of chronic CNI toxicity or in chronic hypertension, what you are going to see is there will be a lot of vascular halitosis you are going to see. There could be evidence of subacute to chronic thrombotic microangiopathy in the vasculature also. Uh, so in the vasculature, a TMA will show mucointimal edema, endothelial cell swelling. That those kind of findings can be seen in chronic. That is why, based on since there is no microvascular inflammation and you find vascular changes of TMA, and the vascular changes of TMA are there in the interstitial blood vessels, and uh, transplant glomulopathy morphology in the glomerular compartment. So based on that, you can say that yes, it is possibly a chronic TB. So Dr. Raghav Gupta is asking, can we diagnose and treat like ABMR in a biopsy where G and PTC are present, but C4D is negative and DSA is negative? What is the percentage of ABMRs with C4D negativity? I must tell you, Dr. Raghav, that C4D negativity in chronic ABMR, it is negative in 40 to 50% of the cases. Only in 60% of 50 to 60% of cases of chronic AMI, you will find C4D positive in the peritubular capillaries. Now, in this case, what you're saying is the where G and PTC are present. So that means there is glomerulitis which is present, there is PTC capillaritis which is present. So surely it is like an active AMI, what you are seeing. The only problem is there could be if C4D is negative, if I find C4D negative in the peritubular capillary, but C4D staining is there in the glomerular capillary wall. So the important thing is don't ignore staining in the glomerular capillary wall. If the glomerular capillary wall is showing C4D positivity and you are finding PTC capillaritis, glomerulitis, even if C4D is negative in the peritubular capillaries, I would suggest that we can think of treating these patients because there is some activity in the biopsy. Because the newer BAMF, the last BAMF meeting, what they have highlighted is there could be antibody mediated rejections where there is only microvascular inflammation, MVI. There is only MVI which are there. C4D is negative, even DSA is negative. They say that there could be anti-endothelial antibodies which are causing diabetes. Or these are anti-HLA antibodies which are not picked up at the routine DS. But I must tell you, this scenario is not a very common scenario. Okay, and if there is, if so the thing is, we need to look very carefully uh, before we consider that this is an entity which is showing only microvascular inflammation or MVI without evidence of any TMA, without evidence of any C4D positive. So only in the follow-up we will come to know whether these patients are behaving like chronic AMR or they are not behaving like chronic. But there is a separate category now in the PAMS classification system which is labeled as MVI positive and C4D negative and DSA. So when Dr. Anisha, so when your differentials are chronic TMA, chronic ABMR in a post-transplant, how do you sign out the report? So I will say that if I'm saying transplant glomulopathy and if C4D is positive in the glomerular capillary wall, even if the C4D is negative in the PTCs, but if I see staining in the glomerular capillary wall, and if I find that there is minimal microvascular inflammation, I would label that as I would favor a possibility of chronic antibody-mediated rejection, and I would also say that I wish to do ultrastructure or EM examination in this case. But I give importance to C4D staining in along the glomerular capillary. The only exception would be uh, because sometimes glomerular capillary wall C4D staining can be seen if there is underlying coexistent diabetes. So I'll be careful about that. But if there is no underlying diabetes and my differentials are only chronic TMA or chronic AMR, I'll give importance to C4D staining along the glomerular capillary wall. Remember that C4D in immunofluorescence, mostly C4D mesengium. So that means C4D is staining in the mesengium that act as a positive filter. So if I find C4D in the mesengium, I know my C4D is working. Okay. But if that mesengial staining moves towards the glomerular capillary wall, that means there is a pathology. Remember that what C4D is a surrogate marker, which suggests that there is an endothelial injury. So endothelium is more towards the glomerular capillary loop and not towards the mesenteric. So if you find staining along the glomerular capillary wall, that means there is some endothelial agent. Okay. So I give importance to glomerular capillary wall sequence here. Okay, what percentage of acute ABMRs can be? As such, there is no specific percentage, what I remember, but I must tell you, there are good number of acute ABMRs which are C4D negative. But remember, with this in the current scenario, where you do flow cytometry, where you do CDC cross match and all that. In this kind of a setting, we hardly see any acute AMR in an ABO compatible setting. We see acute AMRs now mostly in a ABO incompatible setting. Okay, so if we are finding acute ABMR in a setting where this patient uh, uh, a patient DSA, flow cytometry, CDC cross-match was completely negative, it is highly unlikely positive. I see only if it is a sensitized patient, okay, and you have given you did desensitization protocols and then you transplanted that patient. I see ABMRs mostly in those settings. But yes, it is not uncommon. I must say that even acute ABMRs can be negative for C4D. I won't be able to give you a percentage, but I feel there could be 50% of acute ABMRs also, which can be negative for C4D. But as I've told you, it is not a common thing we see with the current kind of immunopathological practices, what you do, where you do all these uh, CDC cross match, flow cross match, and DSA. So we don't see that. But then I go with the morphology. So when I say acute AMR, I'll see if there is TMA, and that TMA is quite diffuse. So what happens is the problem comes is when you find TMA, for example, there are 10 glomeruli. All 10 glomeruli are showing TMA. There are vessels which are showing TMA. I would consider a possibility of acute AMR too. On the other hand, there are 10 glomeruli. There are two glomeruli which are showing TMA, but other glomeruli are not showing TMA. The ATN also is not like very severe kind of acute tubular injury. It is like mild kind of ATN. So if I find mild ATN and 2 out of 10 glomeruli showing TMA, I would consider possibility of CNI toxicity. On the other hand, if I find diffuse TMA and there is ATN which is severe, I would raise a possibility that this could be acute ABMR. But remember that even a recurrent or de novo HUS or TTP can show signal morphology. Always remember TMA again, it is just a morphological term. Looking at the TMA, you can't say that this TMA is due to AMR or this TMA is due to CNIs or this TMA is due to recurrent HUS or TTP. Okay, it is only based on if you assess the complete biopsy. Based on that assessment, you may say, as I've told you, 2 out of 10 glomeruli or all 10 glomeruli. Okay, so it is just an assessment, but majority of the times, when you correlate with the trough levels and everything, it turns out to be correct. So I think it works well when I report my cases. Okay, so can TMA be associated with mild glomerulitis and PTC capitis? It is it is it is a slightly unlikely possibility. What happens is it is said that wherever fibrin is there, it can attract some neutrophils. Okay, so if in a glomerulus I find that there is thrombotic microangiopathy, TMA is there is fibrin deposition, and I find occasional kind of neutrophilic deposition, neutrophils. I would suggest that this is possibly related to this. These neutrophils are possibly related to the fibrin kind of deposition which is there. But if I find neutrophils even in the glomeruli which are not showing TMA, that suggests that possibly it is like more like a acute AML. Can be associated with which TMA is most commonly encountered with CNA toxicity? Acute, subacute, or chronic? Can acute CNA toxicity also cause acute TMA like hysterectomy? Absolutely. I must tell you, if I see 10 TMA early post transplant, I'm talking about ABO compatible setting. Okay. So in a ABO compatible setting, if I find TMA first 1 month transplant, majority of the times it is CNA induced. And what kind of TMA I'll get? I'll get a TMA, like as I've told you, 1 or 2 glomeruli which are showing TMA. And that TMA will involve only the glomerulus which is affected also, like 2 glomeruli out of 10 are showing TMA. Those 2 glomeruli with TMA will show a very segmental involvement of the glomerular tuft. It will not be 100% of the glomerular tuft which is involved. The other thing is CNA-induced TMA, if you look at the glomerular hilar vessel, that glomerular hilar vessel will also show a vascular. So the vascular TMA, what you see in CNA-induced TMA, it is mostly the glomerular hilar vessel TMA, what you see. You will not find mostly interstitial blood vessels with TMA kind chips. But I'm telling you, this is not like 100%. It is just like after seeing so many biopsies, we keep on correlating with the trough levels. So based on histology, if I see a segmental glomerular TMA or segmental vascular involvement in TMA, I would say that this is possibly CNI-induced TMA. If you ask me chronic TMA due to CNI, I don't see commonly chronic TMA. Chronic TMA mostly we see due to either chronic hypertension or due to chronic AMR. But yes, you can see in chronic CNI, that is not you can see, but commonly we see due to chronic TMA, you see in a transplant setting mostly due to chronic. We had some patient with graft dysfunction who had microvascular inflammation in the first biopsy with C14 activity, and then on second biopsy with 1 or 2 months, they had TMA but no microvascular inflammation and C14. Could this TMA be due? Yes, this TMA could be due to ABMR. Remember that. See, C4D has got a waxing and a waning course. It is not like C4D will be present always. Always it will be positive. Okay. Even DSA, they have got a waxing and a waning course. That is why it is said that whenever you say C4D is whenever you want to correlate your DSA with the biopsy, it should be done in within a close range. It should not be like you did biopsy and now you are doing DSA after 2 months. It has to be done within a span of 1 week or 2 weeks. Then only your DSA can correlate with the histology. So when you say there is microvascular inflammation, there was graft dysfunction, and that patient didn't respond, I must tell you one case. I still remember that was long back. I reported one case, and I am very careful whenever I report any ATN post-transplant, post 1 year post-transplant. If there is no history of diarrhea and I find only ATM, okay, I would say that this ATN could be related to early chronic AMR rather than labeling that as ATN due to CNI toxicity. I remember that first biopsy, I labeled that as ATN. C4D was negative. I said that, okay, this ATN is there. I'm not seeing any microvascular inflammation. This ATN is possibly related to CNI. CNIs were reduced and there was rise in serum creatinine. And after maybe 3 weeks or 4 weeks or 1 month, whatever, I saw a repeat biopsy, and repeat biopsy showed diffuse C4D positivity, and there was evidence of some microvascular inflammation. Okay, so I am very careful. 1 year post transplant, if I find ATN only, I would raise a possibility that if there is no episodes of diarrhea, there is no reason for ATN. This ATN could be related to early chronic. Sir, BAF 22 removed acute tubular injury as a feature of ABMR. See, remember that acute tubular injury as a feature of ABMR, it is difficult to remove that completely, I must tell you, because there was entity which they highlighted that C4D negative ABMR, one of the entities, which they said it is based only on ATN. If the ATN is not resolving, and even if C4D is negative, consider that as C4D negative ABMR. But remember that if what I see is, if on the first biopsy I find acute tubular injury, which is there, and I say that C4D is negative, there is no microvascular inflammation, I say that you reduce the CMS, okay, because there is no morphological evidence to suggest to suggest ABMR. If they reduce the CNIs, and despite reducing the CNIs, the ATN is progressive, okay, and they do a repeat biopsy. And if in the repeat biopsy, if the ATN is of a similar intensity as the first biopsy, like for example, the first biopsy was showing mild kind of ATN, the second biopsy is also showing mild ATN, I would suggest that you can completely stop this or replace the CNIs with some other things, okay? But if I see in the second biopsy, the ATN has shown increased severity. So as compared to the first biopsy, which was mild ATN, the second biopsy is showing ATN, which is pretty diffuse. And I've seen some areas where it is progressing towards a severe kind of ATN. And I would say that obviously this ATN could be related to antibody-mediated process. But remember, majority of the ATN post-transplant, it is CNA induced. It is not related to AMR. If it is ABMR, you will find a morphological evidence in form of TMA, in form of glomerulitis, and every second person we biopsy in early transplant period is having acute tubular injuries in biopsy with no other evidence of ABMR on C4D or DSA. how can one suspect ABMR in this situation? Yes, I'm saying we can't suspect. That's why I told you, if you find ATN early post-transplant, your first possibility should be CNS. I remember there was one patient in which 5 biopsies were done. All 5 biopsies showed only ATN, but the all those 5 biopsies, the ATN was always mild. Yes, even at the normal levels of CNI, you can have ATN because some patients are not able to tolerate CNIs even at a low level. So I'm talking about the patient. This I still remember this patient was from Jaipur. 5 biopsies, all biopsies ATN. Finally, I told them just remove CNIs. Okay. The moment CNI is removed, absolutely the creatinine came down to the normal. There was no more. See, always remember if the ATN is not showing any progression, and on the repeat biopsy, second, third biopsies also, you are not finding any other morphological evidence of ABMR in form of glomerulitis, PTC capillaris, TMA. That ATN is related to CNS. CNA normal levels can have ATN, CNA normals can have TMA. Yes, they can have TMA. They can have TMA, but the TMA will not be very diffuse. It will be a segmented. Majority of the times. See, in medicine, it is never like 100%, but what I'm telling you, majority of the times you'll find not a significant. For CPOD staining, which is better, IAC or IC, I'm using immunofluorescence. I do both. I use both methodologies. I feel immunofluorescence is better. Okay? But yes, if even if you're using IAC, that is fine. That's why I use both modalities. If on IF I get some doubt, I do IHC. If on IAC I get some doubt, I do IF. But yes, my protocol is I will do IF first on first instance, since I get a separate code. And for me, when I'm saying C4D capillary wall staining, that is easy to pick up on immunofluorescence rather than on immunohistochemistry. That is why I find very useful if I do immunofluorescence C4D. But that is personal choice because some obviously you need a separate code for immunofluorescence. So obviously there will be nephrologists who will say, I don't want to take 2 course and all that. So that is fine. It's okay. So if there are no further questions, so shall we stop? Puneet, what do you say?
Yes, sir. Thank you so much. I think it was already a very exhausting session.
तो यह थका दिया
Uh,
अरे इतने सवाल पूछे मुझसे
right, sir.
ओके जी
आप
थैंक यू
awaited ही इतने होते हैं, sir. And everybody, the students really look forward for your session. Thank you again so much, sir.
थैंक यू थैंक यू थैंक यू
Thank you,
थैंक
sir.
यू पुनीत एंड थैंक यू स्टूडेंट्स थैंक यू ऑल द बेस्ट
Thank you, sir. Our pleasure, sir.